afternoon, everyone, and welcome to the second seminar for this semester. Today, I'm very happy to introduce our guest, Dr. Daniel Fitzgerald. He's a professor of medicine at Cornell Medical College, New York City. He directs Cornell Center for Global Health, which collaborates in Brazil, Haiti, India, and Tanzania. Dr. Fitzgerald conducts clinical research and trials on HIV and tuberculosis, where the training of international health scientists is central to his research. The floor is yours, Dr. Fitzgerald.
Thank you very much, and thank you for inviting me, and thank you for your gracious introduction. Today, I'm going to talk about from Cornell University, and I was looking that we're twins, AUB and Cornell University, because we were registered with the New York State Registrar of Universities in 1865, but it was just a few months before AUB was registered 1 year later, less than a year later. I'm very pleased to be here. And I'm at the Medical College of Cornell University, which is called Weill Cornell Medical College. And within the Medical College, I'm in the Center for Global Health. And we are faculty who, a group of 20 faculty at the Medical College who work predominantly abroad and in middle and lower income countries, trying to promote health and increase access to healthcare for people in those countries. So for people who are engaged in global health, and especially people coming from the United States, last year, 2025, was a very eventful year. The United States has left the World Health Organization, so we are no longer a member of the World Health Organization and are no longer collaborating and giving information or sharing information with the World Health Organization. And as a global health person, that is really our sort of one of our main missions, is to work with the World Health Organization. The United States also essentially got rid of the United States Agency for International Development, which was really one of the primary institutions within the government of the United States promoting healthcare in lower income countries, really basic primary care, food, clean water, maternal child health. A lot of those programs were funded through USAID. And then more generally, it has been more difficult administratively to conduct research and have grants from the US government in international health. There's much more scrutiny of them. So given those changes, it seemed like an opportune time for me personally to sort of review the history of global health at our institution. What were some of the key values and lessons learned over the years? And then, given recent event, what are some of our future directions? Where are we going? And this is sort of an internal reflection for me, but I also thought it was a good opportunity for coming from the Cornell University and starting to collaborate with AUB to introduce ourselves and where we are coming from and some of our institutional values, and would love to hear your feedback on them. So our mission is training, research, and service to improve the health of people in low and middle income countries, and to protect health worldwide. So sort of this dual benefit: one, providing primary care and basic health care for people in lower income countries, but viewing that also protects everyone's health by assuring that everyone has access to health care. And the training, research, and service is the three-part mission of academic medical education. And I think, as you'll see today, I think it's a very powerful engine and combination for affecting change for the better in the countries where we work. So who we are as a Center for Health in Cornell University. We have 18 faculty members, and we have joint appointments in multiple other departments within the medical school, including the Department of Medicine, Emergency Medicine, Epidemiology, Obstetrics and Gynecology, Pediatrics, Microbiology and Immunology, and Statistics. So it's a very multidisciplinary group. And many of the problems that we face internationally are multidisciplinary problems and require a team effort and team response. We have 5 postdoctoral fellows. Our major programs have been in Brazil, Haiti, Tanzania, and India. A good proportion of our funding is United States NIH funding, and fortunately that has continued over the last year. The areas of expertise in our center are cardiovascular diseases, infectious diseases, and women's health. And I'll discuss those a little bit more. So our first Cornell has a long history of international engagement, actually dating back to the 1800s with a program by Ida Scudder, who was one of the Cornell has always admitted women since its founding, and Ida Scudder was in the first medical school class at Cornell, and then she actually, after graduating, left and started worked in a hospital in India. So really dating to our very beginning, had an international representation. Our center itself dates back to 1964 when the medical college established a tropical disease unit to address the increasing air travel, international travel, and people coming back to New York City with malaria and other tropical diseases. This is a picture from 1964. On the left with the tie is the dean of the medical school, Hugh Luckey. And on the right is Ben Keene, who was the director of the tropical disease unit. And this is on a visit that they were making to Brazil to explore potential collaborations with the Federal University of Bahia in northern Brazil. I'll point out that they were certainly not interested in cardiovascular disease. If you'll notice, there's a pack of cigarettes in the dean's pocket, and there's a cigar in the right hand of Professor Keene. They were much more interested in tropical infectious diseases than they were in cardiovascular health. But they established with the Federal University a partnership that was supported by the Rockefeller Foundation and the Commonwealth Fund of New York City, 2 private foundations, and had 3 goals. One was bidirectional educational exchanges of both medical students and graduate students, so master's and PhD students, between Cornell University and the Federal University of Bahia. And then second was mutually beneficial research, so research that was of interest to United States faculty, but also strong interest locally and with responding to local needs. And then third, that the educational exchange and the research should both be moving towards improving clinical and public health care in the country of Brazil. So with, was forward thinking for its day. This in 1969, so a few years later, the program was directed by the gentleman standing, Dr. Warren Johnson from Cornell University. And then this is him in Brazil, and he spent years there with some of his Brazilian collaborators. And Warren had a couple sort of things that were layered onto this collaboration. One was the first one to receive National Institute of Health, or NIH, research support. And in the US, that's really the gold standard of research excellence is obtaining NIH funding. And so Warren felt that research that was being done in Brazil should be done at the highest level, and that always responding to local needs, but can be done at the best level. The other thing, Warren continued this collaboration for close to 50 years, that he continued going back and forth between Brazil and New York. And his repeated would teach us that growing programs and growing young people is something that is done over decades. It's not something where you pop in, say hi, meet people, and work for 6 months and then take off. It's something, and he would say we're not growing flowers, we're growing trees, and that like growing trees, it takes decades. And so in any of the programs, so this bidirectional education, mutually beneficial research done at the highest possible standards to promote public health and clinical care, and the establishment of decades-long partnerships really sort of became the template for the future of our unit. Over the years, Warren became director of the Tropical Disease Unit, which subsequently became the Division of International Medicine, which subsequently in 2009 became the Center for Global Health. And it became a center in recognition of the multidisciplinary, multi-departmental collaborations that were involved. Talk about another program that started in 1982 and continues to this day. This program started with, actually, this is the yearbook picture from the Cornell University Medical College class of 1975. And circled in red here is a medical student, Jean Pac, who was actually from Haiti, and had been accepted into the Cornell Medical School from Haiti. And he had gone to high school and secondary school in Haiti, went to Columbia University for undergraduate, and then did his medical training and clinical training at Cornell University. When he graduated, he wanted to return to Haiti, and so he joined the faculty in Dr. Johnson's group, at the time, the International Medicine Group. He returned to Haiti, and he was studying childhood diarrhea and the introduction of oral rehydration fluid in Haiti. And when he was called down the hall, this was 1979, 1980, and on the adult ward at the time, they were seeing the adults dying from diarrhea, and no one could figure it out. And so he started, and he thought they were very similar to cases he had seen of people with cancer and leukemias in New York who would die from these opportunistic infections. And so and then a couple of the people had cancers, Kaposi sarcomas, on their skin. And so they started the Haitian study group for opportunistic infections and Kaposi sarcomas. And that was called GESCIO, was the name of their group. And they had cataloged about 80 or 90 of these cases, many with chronic diarrhea, many with Kaposi sarcoma, a lot of them with very advanced unremitting tuberculosis. And that was when the CDC, the Center for Disease Control, reported the first case of AIDS in Los Angeles in 1982, and they recognized that they were seeing the same thing in Haiti. And so JESCIO became a nonprofit. They reported those initial cases in the New England Journal of Medicine, and it was the first description of AIDS, but in a poor country where it more manifests with tuberculosis, diarrheal diseases, and less so the pneumonias that were being seen in the United States. This is fast forward 50 years, and this is Dr. Pop. Today, the JESCIO group became a nonprofit organization. It was recognized by the government of Haiti as a public utility, so it's quasi-governmental organization. It was committed to providing clinical care for people with HIV in Haiti, conducting research to help improve the care and prevention of HIV, and training healthcare workers in Haiti to address this new epidemic. Over time, its mission expanded to other infectious diseases, including cholera, tuberculosis, and then even responding to other national disasters in Haiti. I'm not sure if you've followed the news, but Haiti has been a country that has been beset by sort of crisis after crisis after crisis. Including a massive earthquake that killed hundreds of thousands of people in 2010. That was followed within 1 year by a huge cholera outbreak and epidemic that killed over 10,000 people. Then political instability, and then the president of the country was assassinated 4 years ago, and that has led to the government essentially collapsing, so that today there are no elected officials running the government of Haiti, and the capital city of Port-au-Prince is controlled predominantly by gangs. About 90% of the city is gang controlled, and so you almost, going from neighborhood to neighborhood, you have to go through gang checkpoints to have access to the city. There are currently 1.4 million people because of the gang violence and gang warfare. There are now 1.4 million internally displaced people in Port-au-Prince, and they're living either in shelters in old school grounds, or factories that have closed, or just open fields in tent encampments. And those are administered partly by the Haitian government and partly by UN agencies. Despite this chaos, the group in Haiti, the JESCIO group, continues, and they continue to provide patient care within this context. And these are just some of the numbers to show you the volume of services. 70% of the healthcare centers and clinics in Port-au-Prince have closed. And then of the 30%, many of that are remaining, many of those are operating maybe 1 day a week. But this JESCIO team is functioning completely, and if anything, is increasing increasing the volume of services over time that they're offering. This just shows you the types of care. I won't go through all of them, but care for people with HIV. And these, again, care for people with TB. These are diseases where if you stop your medicines, you die. And so if JESCIO doesn't provide these medicines, then these are people who would live months, not years. You'll also see, unfortunately, in the context of the violence in Haiti, they provide care for women who've been sexually assaulted. They are providing a lot of care for children with severe malnutrition. They, through the International Development Bank, are providing primary care and cash gifts to mothers of children, so heads of household, to try and get food and some income to these families. And they're providing care to close to 20,000 people who are living in displaced camps. The research productivity of Dr. Pop and the Geskio team, and again, this is a Haitian team. There are Cornell collaborators with this, but this is a Cornell team. And if you look at all these papers I've outlined here, I would say 80%, the first author and the senior author are Haitian authors. And it's really, they've established the capacity for the conduct of research. And importantly, we were pleased to be able to speak with the head of research today, that they've been able to maintain this high level of very high quality research in the context of all this civil strife and crises, so that they're able to document what's happening. They're able to address these crises with new methodologies. This list of papers includes papers defining AIDS in the early epidemic, defining the medicines and treatments for HIV/AIDS, the introduction of antiviral therapies. Down the bottom is one that was probably of interest here. When they were hit with the cholera outbreak in the 2010s and early 2020 period, there's an oral cholera vaccine, and Dr. Pop and the team, it had not really been used in emergency situations prior to that. And so they were able to negotiate 100,000 doses that they gave to a very, very poor neighborhood immediately next to their clinics. And they were able to demonstrate that it just shut off transmission by providing it, that it was incredibly effective. And then because of that, the World Health Organization provided an additional 2 million people vaccination, especially in very poor urban settings. And that really helped to tamp down the epidemic. And because of that experience, the World Health Organization now maintains a stockpile so that when there are outbreaks, oral cholera vaccines now one of the tools that is used to stem those epidemics. So again, even this is a local group conducting research in the most difficult of times, but addressing local problems, but doing it in a creative and innovative way so that they're setting solutions for the world. And training, the Cornell Geskio collaboration has had support for training and has trained hundreds of people for a master's degree, PhDs, predominantly healthcare workers who've either gotten degrees in public health or PhDs in epidemiology. And I received this thank you note just about a week ago. This is from Rose Cardell-Richier. She's an RN and she's a midwife. And she's currently working, providing prenatal care to adolescent girls in Port-au-Prince under these very trying times, where most deliveries are at home because there's not enough obstetrics hospitals. And she is really on the front lines in Port-au-Prince providing care. And she recently defended her thesis and earned her master's degree. And she wrote a thank you note to us. And I just love this quote, that I will continue to put my skills at the service of the Geskio Centers and the entire Haitian community in order to contribute concretely to the improvement of public health in our country. And so this is what training is about, is finding people on the front lines, giving her the skills, and she's really coming up with innovative ways of providing care to this very vulnerable population in Port-au-Prince. Jeskio is also engaged now in humanitarian assistance, and many of the themes I've heard just briefly, in the last 24 hours about the refugees here in Lebanon and internally displaced people, they're seeing many of the same issues that are being seen here. Jeskio is offering mobile clinics, and this is sort of pulling into one of the internally displaced people's camp, and they had announced that a mobile van was going to come and provide care, and this was what hundreds of people were waiting for them as they pulled in the driveway. This is just a picture that they bring in desks, they set up clinics, and they just start, and they see people providing primary care. Unfortunately, one of the major issues that is being seen is sexual violence. In the pie chart on the right is the age breakdown. You can see 8% 0 to 10-year-olds suffering sexual violence, 11 to 18, 36%, 19 to 24, 25%. So this is the average over a 5-year period of the number of people who have, women who've reported sexual violence at the Jeskio clinics and at their mobile clinics. And it's just striking that 69% of the women reporting this are less than 25 years old. So this is affecting a whole generation of young women. The care that Jeskio provides, medical care, psychological care, legal assistance, and then social support. So if a young woman is at a IDP camp and there's the aggressors, the attackers are still there, Jeskio will find funds to provide housing somewhere else, emergency shelter to move the survivor away. Again, their ability to maintain the data, respond in a thoughtful way was shaped by their having a research background and being able to quantify things at the highest standard. And for women who've survived sexual violence and for mothers of children that are severely have severe malnutrition, they've started vocational training and other training opportunities for those women. And there's actually in the neighborhood where Jeskio clinics are, the schools have been shut down, and so they've started an elementary school with support from the French government. I'm going to quickly talk about Tanzania and then India, and then open it up for discussion. And I'm going to talk briefly about Tanzania, where Jennifer Downs, who's here from Weill Cornell with me, has really played a pivotal role. So I'm going to just share a few, because then the next time we come visit, Jennifer can I'll leave the door open for her. So interestingly, and I'm emphasizing this for students and trainees here, our program in Tanzania also started with a student, with a Cornell student, and this here is Peter Lejac. He was both a Catholic priest and an MD, and then after his clinical training, he traveled to Tanzania and was working in the city of Mwanza, Tanzania, which is up near Lake Victoria. At the time, the population was 16 million people around Lake Victoria in the area that the hospital served, and there were a total of 15 physicians. So it was about 1 physician per million people. So if the population of Lebanon is about 4 or 5 million, that would mean you'd get 4 or 5 doctors in your entire country. Peter was working as a physician. He also was meeting with community leaders. And the problem was this was a city that's on the interior of the country. It was far away from the capital city. So all the medical graduates stayed in the capital city and very few wanted to go to this very remote area. And so Peter met with the religious leaders and civic leaders in the city of Mwanza, and they decided that they would start their own medical school in order to train people who grew up in the area to then serve as the physicians for their community. Peter returned to New York, and he met with our dean and the leadership of our institution, and they agreed that this would be a new program for our Center for Global Health, to work with Peter to help developing this new medical school in Tanzania. And then, so we had two people who had just finished their medical studies. Jennifer Downs, who was a Cornell medical student, a Weill Cornell medical graduate, pictured on the left. And she had just finished her training in adult medicine. And then on the right is Robert Peck. And Rob had worked actually with me in Haiti as a medical student. And both of them had just finished their training, and both were eager to go to Africa. And so Jennifer went and has done a lot of work in improving women's health care and women's health. Rob worked in the hospital and did a lot of teaching in the hospital. And the two of them really helped establish the clinical education system for the medical school, and worked very closely with a number of fantastic Tanzanian colleagues. And initially, pretty singly focused on clinical teaching to get the first class of medical students. It was 10, and that started in 2003. And then it went 10, 20, 30, it increased over time up to close to 100. And so their initial efforts were more on education, but then have expanded. Jennifer does research in women's health and female genital schistosomiasis. Rob does research on cardiovascular disease. So again, the three-pronged approach of patient care, education, and research. And fast forward 20-something years from at the 20th anniversary of the first medical school class in 2023, they graduated their 2000th MD. 67% of the graduates from the medical school in Mwanza stay in the region. So there's now 15, instead of 15, there are now 1,500. So a 100-fold increase in MDs for the region. This is Dr. Jumani, who is a graduate of the medical school in Mwanza, Bugando Medical School. And he was posted, and sort of as an example of someone, he was posted to a regional hospital, not in the city where the medical school is, but actually even more remote, a little bit more of a rural area. And he was the physician for a primary care center. And then in 2025, he noted several cases of people coming in with high fevers and diarrhea, and they were bleeding a lot. And he recognized that this could be a hemorrhagic fever, and so was providing care to these initial patients, helped notify the public health officials that something was going on. And then ultimately 18 people developed Marburg virus, which is like Ebola, very contagious, very deadly. And then Dr. Jumani also developed Marburg. He acquired it. There were 18 people who caught the Marburg virus, and 15 of the 18 died. Fortunately, Dr. Jumani survived. He was only one of three survivors for that outbreak. But his heroism in the face of one of the most deadly viruses known, and his commitment to continue providing service, and he still works out at the same hospital and clinic, just shows you the importance of training people and having a young, bright, courageous physician on the front lines, providing basic primary care, but also being there to alert people so that this outbreak didn't get larger. Finally, I'll just a couple more slides on India, which started in 2009. And it's with two organizations, the Deep Griha Society, which is a public health organization, and the BJ Medical College. And this program starts with another student for the public health students and other students here. Right here, this is Jyoti Matad, and she was actually an undergraduate and was in India on a one-year overseas learning experience from Cornell University that Cornell has in collaboration with India. This was her house mother, and she's right in northernmost part of India. And during Jyoti's stay, the house mother was pregnant and then started developing fevers. While Jyoti was there, they raced her to the local hospital, who said they were not equipped to handle a pregnant woman who was so ill. So then they raced her to the next level hospital, and by the time she got there, she passed away. And that really cemented that event, cemented Jyoti's commitment to women's health, and especially infectious diseases that affect pregnant women disproportionately. And so, fast forward a number of years, Jyoti is now a senior professor at Weill Cornell and is a member of our faculty. And she works with two organizations in Pune, India, which she tells us is a small city, a small little town in India of about 3 million people. And the Deep Griha Society, which Jyoti has been working with them since 2001. And they provide community-based care, especially focusing on maternal child care. And the BJ Government Medical College, which is has a large obstetrics and gynecology department, and she's worked with them since 2009. And again, both in helping with clinical service and public health service, conducting research, and then providing training really at all levels, from community health workers to physicians to graduate students. And this is just an example of some of the research studies that she conducts to improve care for pregnant women. A lot of studies looking at tuberculosis, which is more common in pregnant women and affects them more severely. High rates of gestational diabetes in India, and so she's working on methods to improve primary care for pregnant women. So I'll end with some lessons learned from the 60 years of Cornell University's global health. And this tripartite or three-part mission of service, research, and training, they are it's a very powerful engine for health improvement in lower income countries. I think it's why an institution like AUB is so important. I would say, I know people will say, oh, there's a crisis going on, or, oh, there's, been an earthquake, or there's been this or that. So therefore, maybe you should take some time off from research or take time off from training and just focus on service. I disagree with that. I think in times of crisis and in time when things are challenging, it is even more so when you have to be teaching, and even more so when you have to be doing research to document things and to make sure that we're providing, resources are scarce, personnel are scarce. We want to be doing the most effective thing and providing people who are in these challenging circumstances with the best possible care. So I think having institutions that are capable of research, clinical and public health service and training are more essential than ever in those contexts. For US organization working in this context, Dr. Johnson's lesson from many decades ago that it needs to be mutually beneficial and there has to be decades-long partnerships. And it's really built upon trust. It's professional relationships over time where you trust the other person and you trust that this is going to benefit both sides and that you both have a common vision towards improving healthcare locally. And I can't emphasize enough the importance of our students and trainees to global health. So many of our initiatives were spearheaded by students who stepped out, or trainees at various levels who had a vision and stepped out and did it. And really our role is to find them and support them. And also the heroic commitment of our colleagues to primary health care for everyone. Dr. Jumani, Dr. Rose Cardell, who our trainee and midwife in Haiti, that their commitment to providing healthcare, it's almost unfathomable how committed they are, and just an inspiration, I think, for all of us. And the cutting edge research prompted by local insights and local needs. Some people try and paint this picture that there's a conflict between locally responsive research versus like really important international research. I think it's just the opposite, that the best insights and the most cutting edge research is one that's prompted by a local observation and someone who's on the front line and seeing the problem and understanding it and sort of taking the literature and taking what we know and trying to address it the best way possible. Whether it's saying, hey, aren't there these new cholera vaccines? Why don't we, everyone's getting cholera. Wouldn't this be a good place to use it? Or Dr. Pop saying, well, this is odd. We're seeing adults dying from diarrhea. Those initial observations are those problems that are local quickly become global. And it's the people, the sentinel people on the front lines who are seeing them. If they have the tools to investigate, document it, and pull the data together, it's only going to get it quicker to understanding it the global so we can all respond together. So sort of future directions for our Cornell Center for Global Health, really following the leadership of our colleagues in Haiti, Tanzania, and elsewhere who have demonstrated heroic commitment to healthcare for all. There is unfortunately a lot of noise of I think these days of other leaders saying we don't need to care about people who are refugees, or we can just do healthcare for ourselves and the heck with the rest of the world. Well, maybe we'll do a little sentinel work in case there is Marburg or something so we can stomp it out, but we don't have to provide healthcare. and that I choose not to listen to. But these heroic leaders who are out in the front line, they're not even, it's just their nature that they feel everyone has a right to health care. Everyone has the dignity that a young mother, pregnant girl, 19-year-old in Haiti deserves prenatal care. Those are the leaders that I choose to listen to. We need to keep the training pipeline flowing for the next generation of international and United States medical students, residents, and postdoctoral fellows interested in global health. That's the future. And that's where new ideas are going to come from. That's where new programs are going to come from. And so we have to keep them trained and in the field. We can't lose a generation of trainees. The long-term partnerships and growing trees together, we need to recommit to that, because now more than ever, those long-term partnerships are needed and need to be fostered. As I said, respond to the local public health emergencies as we've done for AIDS, cholera, earthquakes, Marburg, other crises. Exchange findings between countries. We're finding things that we've developed internationally. We're working more and more actually with the New York City Public Health Department. And when they hear some of our presentations, they say, that's really interesting. We could use that in New York City. So lessons, so I view global health more as becoming a sort of a healthcare marketplace where people can come and say, oh, that might work in my neighborhood. That might work for us. And that there are creative ways people are providing primary care around the world. And we should all be borrowing from each other, because I don't think anyone has the answer right now. I don't think there's any one country that can say our healthcare system is perfect. I think we're all missing facets, and oftentimes those things are abroad in different countries. And then I hope, this is aspirational and hopefully an aspiration here too, to build a long-term partnership with you here at the American University of Beirut. Thank you very much.
Thank you for a very interesting and eye-opener presentation. So we can have some questions from the floor. Anyone? Yes.
Thank you for the very insightful presentation on the Center of Global Health. I wanted to ask, because you mentioned services that are provided for those who unfortunately experience sexual violence, and they range from medical services to legal and social support. I know this might be a bit beyond the scope of the Center of Global Health, but I wanted to ask if there are any initiatives that target the perpetrators of sexual violence. Thank you.
In the context of Haiti, have done work with the government to address it and with the police force. But right now, 90% of the city is controlled by gangs. And so actually it's not the ultimate solution, but it's a short-term solution. In all the IDP camps where our colleagues from Haiti are working, they establish a local community council within the IDP camp, and it has to be 50% women. And they do education for both the men and women residents on the risk of sexual violence. And actually, it sounds simple, or maybe overly simple, but they actually hand out like alarms for women to have provide solar panel lighting throughout the campuses, provide whistles. So if women are going to the bathroom at night, they can call for help. And since they've started that, there have been a number of assaults that were averted. I don't know if you know any, but Haitian women are pretty tough, and when they get angry, have to be careful. And so they know when like a whistle gets blown or when these horns gets rung, that someone's in trouble. And the men and the women run and go. So creating that's not a long-term solution perhaps, but in the short term it is trying to deal with that issue of prevention. And they've documented that in the camps where they do that intervention, they drop the rates dramatically.
Thank you. Any other questions? Actually, I had a comment. I mean, how do you select those countries? I know there were, at some times, there were students at the medical school, and that was the start of a collaboration and a partnership. But is that always the case? I mean, did you select Tanzania, and how did you select, the other locations where you have established these projects and relationships?
I do think it started with the relationships, and then it just grew, it sort of grew organically. Like I know for Brazil, the dean of the medical school, there was initially just a very small student exchange. And then the dean of the medical school in Brazil, this is in the early 60s, his son was a medical student and rotated up to New York. And he came back and told his father and said, oh, this was an amazing experience. We should expand on this. And his professor was the dean. It just happened he took a class with our dean, who was pictured in the picture. So the dean from the father dean of the medical school in Brazil called the dean of Cornell and said, I want to thank you for training you did for my son. Could we build upon this? Let's. And then he invited him down to come visit. So I think it's a very personal, organic thing, and it starts with strong relationships. I mean, I can assure you, I have not thought strategically about where we want to put the dot. It's people. You meet people and you say, wow, that's inspiring, and that would be someone wonderful to work with, and then it grows from there.
I wonder that. So if the nature of how it started could maybe impacted how the duration of how long it remained, this relationship.
Yeah.
It could be. I'm not sure. I was just thinking about the locations and the collaborations that you have. So. And
we don't have that many.
No, not that many. Yeah.
Yeah. And so it's really sort of, I think I guess I should forewarn people, we move in for decades. We're like the guest that never leaves. But no, but I think when we start something, we're thinking long term.
Long term, yeah.
Yeah, not we're going to pop in, going to get some blood samples and pop out, but more sort of how can we work together over the long haul?
Yeah.
And that depends on the people.
Of course, yes.
Yeah.
Any other questions? Yes, we can have one more.
Yes, wait. You have to use the microphone for the question. Thank you for the nice lecture. And I'm a finalist, MBH program graduate from the AUB, and I'm from Sudan. And I'm doing my graduation project on the deployment of oral cholera vaccine in Sudan under the protracted crisis situation. And my work is based on that. There has always been an overuse and over deployment of oral cholera vaccine and over reliance on it, which weakened the other 8 pillars of cholera control and response plans. So any work has been done disregard in that similar context, because I'm compiling documents to analyze the situation from different points of view.
Sort of concomitantly with the cholera vaccination, they did also created chlorine factories. And so those can be relatively inexpensive and they can be set up very quickly. And then you can give people bottles of chlorine with a chlorine cap so they can chlorinate their water. And then doing education campaigns that it's good if your water has a little hint of chlorine taste. That means it may be safer. The other, I don't think we need to choose do you want front wheel tires or back wheel tires on your car? Or do you want a left wing or a right wing? I think we should do both. We should be doing stable water supplies, stable sanitation supplies, and we should be doing cholera vaccination, and we should be doing short-term water improvements with chlorination. So I don't feel like they're in conflict. My sense is in very unstable regions where you get cholera, the governmental infrastructure to do large-scale infrastructure improvements like developing sewage systems in poor, very, very poor neighborhoods is usually it's usually something that's not going to be done in a year or two. It takes decades. So they should all be done. I don't think we should be forced into false choices of only use cholera vaccine or only do infrastructure for sewerage. We should do all of the above. Yeah, thank you.
Thank you, Daniel, for today's talk. Thank you, everybody, for attending.